pleasure of introducing my colleague and friend, Kristy Deep. Oh, that light's bright. Kristy Deep, and just an amazing person. I'm going to stand here again. Just really so excited that she's here today. I had the pleasure of hearing an earlier version of this talk maybe a year ago at Medicine Grammar House. I said I told Dr. Moore we have to hear this talk. So just to give a little information about Dr. Deep, she is a native Kentuckian from Breathitt County, correct? And did all her training at UK. So she has been through the process that you guys are going through now, a lot of you. She is currently professor of medicine, vice chair for education, and the RPD for internal medicine. So she works with learners a lot, and also on the other side of things, works with faculty, teaching them how to be good educators. She also has a master's in education policy. I think that's about it. So, but welcome, Dr. Deep. Thank you for coming today.
Hi, guys. It is awesome to share this with you. And as I look across the crowd, I think what's noticeable is we have a wide representation of generations in the room, which is the case in medicine these days, capital M medicine. So what we're going to talk about today is how we as academic institutions can both adapt our teaching and learning practices to the people in this room and folks who are going to be coming along for the next decade or so, when you all in the front of the room, current residents, make that flip and become faculty. So I have nothing to disclose here.
Just click once.
Yeah, I know. So we're going to review some generational tendencies and how they impact medical education. And I want to call out up front, loud and clear, we are not here to bash any one individual generation, not at all, or demographic group, but we're going to talk about ways to understand how each group approaches work and learning and teaching, and hopefully talk about some strategies to engage multiple generations of learners in this medical education process. Now, if you were to walk among the halls and ask older faculty, like, tell me about learners today, kids these days, close your eyes, what would you envision? I think many educators would say increasingly on college campuses and in medical schools, this is what they envision: empty classrooms. Even before the adaptations we had to make to the COVID pandemic, there was a trend toward increasing absenteeism in classrooms that with a shift toward more individualized learning, Echo, 360, the Captivate, with using technology that students could stream, could live stream, or record and view later lecture content. So if I'm able to then sit on my couch in my jammies at the appropriate time of day for my brain, and where I can speed up and slow down and pause and take notes, wow, doesn't that seem like the tools that can really help me learn better, help me kind of individualize my educational experience? So the empty classroom phenomenon isn't about lazy people that don't want to get out of bed in the morning. I think it's increasingly recognized that this is a shift in learning style and learning preferences, but it's caused a lot of consternation in college campuses and in medical schools, where we have older generations of faculty who see this and feel that, oh, well, learners don't want to come and learn from me. They don't care about their learning. And it's that divide, that kind of like that difference in perception that underlies some of the challenges that we're going to talk about today. Now, friends, we have been here before. Gen Z isn't the first generation that we've been like wringing our hands around, right? Like, oh, what are we going to do? Change is the only constant when it comes to, social constructs. So remember, in the late 60s and early 70s, these were the guys and gals burning their bras, protesting the Vietnam War. And people then were like, oh, what are these hippies? Like, when are they going to grow up? How are they gonna like live in the real world. And they became the baby boomers. These are the same people, right? So this idea, this idea that like, oh, the way you're acting when you're 20 years old, like means that you are going to be unsuccessful as an adult. Full disclosure, back in the late 90s, this was a publication in a medical education journal, like, ooh, are we ready for Gen X? Right? That's me. Then the millennials came and we were wringing our hands and like, oh, what are we going to do? And there were publications back in the 2010, 2012 era, 12 tips for facilitating millennial learning, right? Like we've been doing this over and over again, friends. It's nothing new. So let's talk about the presence of some of the main generations in medical education today. We'll give the baby boomers a pass. But let's talk about Gen X. Look back, Gen X, which is full disclosure, my generation, the Breakfast Club, right? Like this was the defining pick of our generation. We were cynical, we were ambivalent, we were slackers, we were latchkey kids. We were defined as the lost generation. Holy cow, what did these kids act like when they were medical students and residents, right? But somehow we became hopefully normal, responsible humans. And the millennials, where the defining code of the era was like, everyone gets a trophy. The helicopter parents like were there hovering to make sure little Johnny and Susie, everything was okay. Now enter Gen Z, also known as the iGen. So this is the era born 1994 to 2016-ish. So honestly, a lot of our medical students today and residents, earlier residents, are kind of in this cohort. Now, what I will say is that there is, amongst all these generations, there are large scale generational tendencies. There's also a lot of individual variability that stems from maybe where you were in your generational cohort. So like people who are near the cusp, right? So like late Gen X, early millennial looks different than like hardcore born in the 90s millennial. Exist. And then finally, parenting style, what your sociocultural community was like. So variability within these. So we're going to talk about some generational tendencies. Now, what has really defined Gen Z is ubiquity of technology. And I want you to pay attention to this timeline here, right? Of like, these are folks who, as you all know, like had technology from the early years. Versus I was 30 when an iPhone first came out. That is why I still text with one finger. Right? Like I can't do that. Instagram, Snapchat, TikTok, technology that has now been seamlessly incorporated in the day-to-day lives of learners. So I love this chart because it kind of lays out and allows you to kind of compare and contrast and think about some of the qualities and characteristics of the generations that we see today. So you can look at the birth year then, but I also wanted to think about like, who were the parents of each of these generations and how did that impact how they shepherded their children through life? So if you think about Gen X, my generation, our parents were the baby boomers, like they were busy like building their own careers and very self-absorbed, so they didn't pay attention to their latchkey kids. The millennials, their parents were either late baby boomers or early Gen X. So Gen X, those early Gen X parents who had been ignored by their own parents thought, I'm going to make sure my little Johnny and Susie, like, I'm going to clear their path. I'm going to like love them to death. I'm going to like be the suburban soccer mom and like snow plow all obstacles out of their way. So they're going to like have this beautiful curated experience. And then finally, I hope that some later Gen X parents like myself, my kids were born in 2004, 2007. I think we saw that and have seen the not always great outcomes that came from putting our kids in a bubble. And maybe that pendulum is starting to swing back and emphasizing a little more life skill development that we'll see. So how else do we kind of like sum up and define some of the qualities of these generations, particularly as it pertains to education? So millennials, Gen Y, the guiding principle when working with learners of that era was like, I need it now. I want you to teach me, like professor, like you've got to like, just tell me everything I need to know. I need all of your knowledge, give it to me. Whereas Gen Z is like, hey, no biggie, if you're not doing a good enough job for me, I'll find it somewhere else, right? There's a YouTube video out there that will explain this as well or better than you can. In terms of like their strengths, like the millennials, big into collaboration and group projects. That is how their educational experience went, K through 12 and beyond. Whereas Gen Z is not so much into the group projects. They have, instead of the everybody gets a trophy, they're more comfortable with competition and really personal excellence, and much more comfortable with technology and independent work rather than collaborative group projects. In the work era, the millennials, their motto is kind of like, we'll work hard, but you got to meet my needs, right? You got to make me feel secure and loved and give me the things. Versus Gen Z is like, hey, I'll do whatever, but just like, let me do it on my own time, wherever I want. And we're seeing that both in the corporate world and in medical education. So distinctions about Gen Z. Let's not lose sight of all the amazing qualities that this generation, that many of you all have and bring to the table. They're our most diverse group of learners in medical education. They are determined, entrepreneurial. Gen Z has a bit of a people-pleasing vibe generationally, but that's also coupled with a desire to really make a lasting difference. Those are the amazing positive qualities. They're distinct in kind of, they've grown up with ubiquitous technology, are in general cautious and pragmatic about some things. I'll share some data about, of course, none of this applies to the people in this room, but in large groups, diminished verbal and social skills, shortened attention span, and some evidence about mental health. So literacy, there has been a very clear documented decrease in pleasure reading, in amount of time spent reading for pleasure, for work. Is this the death of books? Are medical journals and long form article manuscripts going to go away? What is their future? The SAT and the ACT has shown for the first time in history documented declines in particularly the verbal score of the SAT. Students are probably getting less experience with critical analysis, of being able to like develop arguments about topics. When it comes to attention span, one of the, and I think this is more of a physiologic, this is not about interest, but there's a physiologic change in the time that people spend reviewing material. Researchers have done studies where they like monitor people's laptops or computers or screens of any sort and see how often they task switch. And task switching happens on average every like 20 seconds. And I think the other key thing for us as educators, and I guarantee you all med students, especially in the back, right, have experienced, is reliance on self-instruction. I love this quote. This was about kind of in the undergraduate space, but if my professor isn't that interesting, I can find the same information on YouTube by maybe someone who's more interested, who has animated graphics. And yes, that works. Great. But I think this question about self-instruction comes up when we'll talk about later about the ability to like assess quality and content, validity of content. So when it comes to medical education, what is the self-reliance look like? Anki cards. Who here has used Anki cards? Raise your hand. Yes. Okay. Anki cards can be great. Spaced repetition. It comes from a very good place of like, of pedagogy, but it all depends on like, what decks are you using? How credible are they? Are they geared at the right level? Sketchy micro. Everybody loves sketchy micro, right? So for those of you who don't know, sketchy is all about like these kind of silly little cartoons and pictures. So this is to memorize, to learn the seventh cranial nerve. You imagine a princess who's holding a mask on a wand that is in the shape of a 7 who's riding a chariot because it's a motor nerve. Huh? Can't you just know that the 7th cranial nerve has the face? Dawn's like, what? Yeah, this is sketchy. Yep. Podcast. More stuff to remember than just the cranial nerves. But it works, right? Like kids these days love it. So podcasts, divine intervention podcasts, go to Reddit, friends, and you will see all people are spending hours of time on Reddit talking about what resources to use to study to do well on step 1 and step 2. There's Amboss you can buy for $400 a year. There's Boards and Beyond that you can buy for $3.99, blah, blah, blah. So increasingly, these are the resources that our students and residents are using over and above or in place of the content that we are providing. Work expectations, there's been a documented decrease in the percentage of young adults who have worked throughout the teen years. So folks are coming up to residency often as this is their first job. And that's an adjustment. Perhaps we need to do a better job with attendance expectations. They have less experience working in teams and as collaborators and often need very clear expectations. Now, interestingly, people who came of age in that 2008, 2010 timeframe of like the Great Recession here in the US witnessed their parents or family members maybe struggling with job security. So there was a thought that perhaps people who entered medicine in that era maybe came for a different reason than long ago when this was a profession with a calling. Perhaps this was increasingly viewed as, hey, I want to go to school for a long time, but then I have job security and a guaranteed 6-figure income. There have been impacts of the reliance on interactive technology in terms of interpersonal communication skills. Researchers who study conversational analysis show that there's been documented ability to have the art of small talk. The art of conversation is perhaps a vanishing art. So people have different social skills, right? Not better or worse, but just different social skills than generations before, and perhaps those that are required in the clinical setting. My kids use Snapchat as their primary means of communication. But this also means that because you're increasingly operating in a virtual space, there is less opportunity, there's less need to use nuanced conflict resolution skills. And overall, there's been a clear tendency to express more criticism of both self and others. So we see this a lot in the cancel culture, as well as in the educational space, more candid, let us say, faculty and peer evaluations. So I was reviewing all of our student of faculty teaching evaluations a few weeks ago, and I came across this one. Third-year medical student writing about a seasoned attending. I would highly recommend using visuals when teaching, whether it be drawing on the iPad, a printed diagram, whiteboard, etc. Teaching that is inclusive towards varying learning styles, auditory, visual, kinesthetic, would better engage students and help with overall content, retention, and comprehension. I would suggest also teaching in more quiet settings. They were in the ED was very populated and loud. Yes, sure. This is great pedagogical practice. The idea that a junior medical student recognized this need and, quite frankly, had the to write it on a faculty, the care, but this shows you could also say wow, this person really cares about their learning and the learning of students for generations to come. But you can also imagine Julia being the faculty member who might receive this. Maybe feel a little huffy, seriously? You're complaining that I'm teaching you in the ED. We got 20 patients to see, and you're complaining that I don't have a whiteboard that I carry around in my pocket. And then finally, life skill development. Oh, as someone whose own child and children of my friends have embarked on their undergraduate career, a very clear deficit that people are entering young adulthood is life skill development. Folks are exiting adolescence with little skills in personal finance, meal preparation, car and home maintenance. This was an actual chat on a parent Facebook page for a college student. Parent, if you have not equipped your child with the skills to obtain food by the time they're over the age of 20 and embarking, like, yeah, like that, yeah.
I would say just that there is a Loyola University student parent page is kind of amazing to me.
Yes, no, I promise you, every single college and university has a parent Facebook page. And if you monitor the chat on here, whoa, you will fear for the future of our. So, and not to make light of this next point, but probably one of the biggest demonstrable differences in this generation is the burden of mental health, stress, and anxiety. The Stress in America survey has been done by the American Psychological Institution for decades. And there's been a really significant uptick in the impact of particularly anxiety in young adults. We have seen across life, but particularly in undergraduate medical education and graduate medical education, a high need for counseling resources. And it is our job to meet that need and provide it. The other thing that has been shown is that this then translates into learners, when they enter the clinical setting, having a sometimes very strong response to adverse events or errors, even very small ones, right? I make one mistake, it's a near miss. The patient might suffer a slight delay in something, but not a catastrophic high morbidity complication. And the emotional response to that often needs a lot of support and guidance. And I think that's something that we as participants in the medical education community need to be aware of and meet that need. So if we summarize, what are some of the learning preferences of this generation? They want teaching that is individualized, right? Like I want to do it on my own time, the best way that I learn, self-paced, self-directed, using a panoply of resources that are often very engaging, but they want it to be concise and organized. Don't waste my time. But yet they want teachers that are passionate, who set reasonable expectations, that provide immediate constructive feedback. We'll talk a little bit more about that later. And that help prepare them for professional work and life. They want that life skill development to be part of their education, and also here to provide a lot of reassurance and emotional support. So now that we know a little bit about this generation, let's think about common behaviors or things that we see, that older faculty might see, that are easy to misinterpret. So you see someone standing off in the corner staring at their iPhone. What's your assumption, Dr. Conklin?
Are they in my clinic?
Like, hey, are you here to work? What's up? Aren't you supposed to be working? Like, I'm thinking, like, I use my smartphone to like do Google Maps, right? Look at my pictures, right? I might be thinking, oh, they're like looking up what's on Netflix, but really, like, this is maybe how this learner is accessing the medical literature, right? I'm reviewing, hey, I got a second here. Let me just pull up and look up the mechanism of that drug. Standing on rounds in the ICU, it's a emotionally charged situation. The dedicated faculty here is talking about ventilator management. And you might see this learner here that looks kind of like hands in the pockets, staring away. He looks bored, right? I'm bored listening about ventilators. Nope. But maybe this is what she's actually thinking. I've never seen someone this sick. I've never seen someone die before. This is really scary. And if we miss misjudge or misread some of these behaviors, we're missing an opportunity to help coach our learners where they are. So now that we know a little bit about our current generation, some of you, what do we all need to do? I think for medical education systems, by and large, we need to adapt. All right, so this is the mud skipper. This is a fish that learned to walk. Not that retained the ability to walk, right? Because back in the old days, right? Apparently we were on the ground, we went to the seas, we lost our legs. And this fish learned to walk on its front fins. If a fish can learn to walk, we in medical education can adapt. So why? Why should medical schools and residency programs and faculty and departments be committed to doing things differently? Because we want to retire. We can only retire when we make you all amazing providers. So we're going to talk a little bit about some tips. How can we change what we do? How can we structure education to best meet the needs of this generation? This is a absolutely fabulous article. Anyone who's interested in med ed should check it out. All right, number one. Thinking about that list, start at the foundation, right? I think if we are increasingly seeing learners who have less life skills, time management skills, we have to somehow bring them up to speed in that space before we can layer on the complexities of what it takes to be a physician, right? So whether we want to or not, this is something that undergraduate medical education, that graduate medical education has to take on. So when it comes to time management, I love this quote. While faculty may feel that they are offering kindness by relaxing deadlines, in reality, these actions may be counterproductive. Holding students accountable to hard deadlines can promote the development of time management skills, period. It's like tough love, right? So what skills do learners need? What skills can we share with folks in this space? How many people have a calendar? Okay, when did you start using and living and dying by your calendar? Third year med school, fourth, like undergraduate, third year, fourth year, right? Like when that got complex, right? So like that is a skill that we have to get people to-do lists. Manage your inbox folders, tasks. It can be low tech, it can be high tech, but the skill we have to build. And educational programs have to ensure accountability. Sorry, program coordinators, like this is now their job. My program coordinator is like pulling, you've got to fill out your Medicare application, you got to sign this form, here's your contract, sign your charts. And other ways that this manifests in terms of of equipping folks with the time management skills is maybe for big projects, we need to scaffold them better instead of saying like, hey, resident, student, go write up this case report or go do this research project. We need to be mindful of maybe breaking that into small chunks and having short check-ins. Like, okay, I want you to do the first 2 pages of the IRB application. And then on Friday, let's do a 5-minute phone call. Make sure you don't have any questions, lest someone like spin their wheels, suffer in silence, and maybe not feel comfortable raising the hand and saying like, hey, I don't know how to do this. I need help. Because help seeking, generationally, something also that folks are struggling with. And we need to normalize that help seeking, whether it's for mental health, physical health, or just like getting people comfortable acknowledging knowledge deficits. But are they scheduling PCP appointments, utilize the counseling service that we provide for all students and residents, and just making this something that we talk about and normalize. All right, next up, as we enter from their personal development into educational skills. As I said, there's demonstrable evidence that reading stamina is on the decline. What's like the ophthalmology textbook? We have Harrison's internal medicine. What do you got? Like, do you all have your version of Harrison's?
BCSC series.
It's like 12.
BCBS, yes, okay. Big, but it's big, right? It's like this, it takes up this much room on your bookshelf, right? And the idea of like opening page 1 and reading is probably, woo, like not gonna happen, right? And maybe that's okay. Maybe you don't have to read BCBS front to back, but there are probably going to be some things that you need to learn through reading or thinking about your future academic careers, right? Grant reviews, stuff that you're going to have to build some reading stamina from. How can we do that? Foster written professional communication skills. I think this is something that probably the reliance on short form, instant communication, messaging, texting, chatting has eroded. So when you need to write an email, how can we give you tips to make it not just be like vomiting words on a page, talking about capitalization, punctuation, formatting. Now, there are times when you're chatting with your friend, yes, you can skip the periods, paragraphs, whatever, but you also have to know, when do I actually need to use more formal written communication? And I think one of the beauties of younger generations in medicine is they don't always feel that sense of hierarchy, right? We've intentionally created this environment where it's like, hey, it's a little more egalitarian. Hey, Kristy, the program, like we're accessible. Come hang out. I'll text you, you text me. But maybe when you're like emailing the chair of a department about something, you should probably capitalize things and use proper punctuation. When you're trying to find a job, we've developed a whole cover letter workshop for our residents to be able to write and format a formal letter and put it on letterhead and know how to write things well. When it comes to information and learning, teaching information management skills. So one wonders what the future of the medical literature is. Going from long 15-page manuscripts that, let's be honest, nobody reads anymore, right? Like you rarely read the whole thing and you probably shouldn't. Increasingly, specialty societies, meetings, even journals themselves are really highlighting graphical abstracts or brief videos that summarize late-breaking, practice-changing articles or studies. We should probably incorporate those, but we also need to still teach critical analysis. So our learners who, yes, maybe they like and can easily digest the short form, but how do we know whether that's garbage or not, right? Like that skill of critical analysis is still really important. When it comes to learning resources, there are 1,000 out there. I lost count of how many kind of like medical podcasts that you can subscribe to these days. Everyone and their brother can put YouTube videos out there that teach you internal medicine. Are they any good? I don't know. So I think what we in the educational community have to do is vet those to curate like, hey, here's some good stuff. Be wary of the garbage. And here's how you can kind of suss that out, right? If something is like endorsed or sponsored by the American Ophthalmologic Association, maybe it's pretty good. If it's like some dude in his bedroom, maybe not. I think also, given that I am like in a lecture hall, I will say this with caution, but we probably need to recognize the fact that like standing up in front of people and lecturing with some PowerPoint slides in the back isn't necessarily the most effective learning style for anyone, really. Where can we replace lecture with self-directed content that's of high quality, and then save in-person activities for application, for interactive, skills-based learning? It's something that we've been grappling with. And then we need to provide real-time feedback. And this is, I'll be honest, I think this is a space where the pendulum is swinging a little bit, right? Like we survived the millennials who didn't want constructive feedback. They wanted the trophy and to hear I'm perfect, right? Like mama told me I was all along. Whereas increasingly younger, the next generation of learners is really wanting formative feedback. If anything, if you don't give them formative feedback and tell them how to do better, they think you don't care. That's great. That is a wonderful tendency, right? Of like that I want to be my best. I want to learn and grow. So if you don't tell me how to do that, if you're just leaving me there with the spinach in my teeth, if I'm doing something wrong and you're not helping me fix it, then shame on you, right? Tell me when I got spinach in my teeth. They are open to constructive feedback. Team dynamics. So this whole, we've talked a little bit about the different interpersonal communication tendencies of younger people. And that has probably led to some impact on team dynamics. They've seen this in the corporate world. We've seen it in the educational spaces where teams need more assistance in resolving team dynamic issues, in conflict resolution, in defining roles and responsibilities, in sharing those. And then finally, how do we do all that and support brave spaces for learners? One of the things that got me interested in this topic was this book, The Coddling of the American Mind. Anybody heard of this? Yeah, so it was written, it's a wee bit controversial, I would say. It was written by like a cognitive psychologist, and I think the other one's maybe an educator. But and basically how some of these well-intentioned parental and practices in secondary education and colleges have set up inability of learners to navigate conflict, to navigate controversial ideas. So that colleges were all about providing safe spaces that were protecting people from conflict, from emotional risk, right? If something was controversial, we would just like ban it from campus. We wouldn't talk about it. Now, I don't know about you, but that's not the real world that I live in when I'm like walking the halls of Hotel Chandler, right? There's some discomfort there. There's emotional risk when we're like jumping in and caring for a very diverse patient population. So we have to help prepare them for this, right? To get okay with feeling uncomfortable. There is no way you can manage medical education and residency without a lot of discomfort along the way. You have to be okay with making mistakes. We want them to be small, but it's okay to make mistakes. You got to know what you don't know. And this is increasingly a skill that we actually have to like develop and foster in our learners. And they need to know that we're doing this, that we're not throwing you into the deep end of the swimming pool because we don't care. We're doing it because we do, because we see what you need to be able to do. And we are going to help get you there with support and show you why this is so important. All right, so let's think about a couple of examples that might come up in our clinical educational world. You've got an M4 students, they're just starting their inpatient acting internship, right? They want to do ophthalmology, they're all excited. You want them to really jump in and engage, right? To own their patients, go see them, come up with a diagnosis, articulate their rationale. But you've noticed increasingly this year, maybe last year, that students are just kind of hesitant. They seem apprehensive about patient care. They just don't know how to get involved, not sure what to do, and seem to be awaiting very specific instructions. Feels like you used to be able to just say like, hey, new consult, 33 in the ED, go see him. And now, like when you say that, you get the look of like, what exactly do you want me to do? Right? Because they want to be successful, right? So let's talk about what are some of the generational tendencies that might be at play here.
Or social skills.
maybe poor social skills, right? Different social skills, different, right? They just like. Not better, worse. What else? Go see the new consult.
Clear expectations.
Want clear expectations, right? Like I want to be successful in this. And for me to be successful, I need to know what exactly you want me to do. Do you want me to go and like take a history? Do you want me to go and like review everything? Do you just want me to chart stock them? How much time do you want me to take, etc.? So what can we as educators do to help bridge this gap? Giving specific expectations, right? Like early and often, setting expectations is one of the most important adaptations that we can all make to help newer learners be successful. And I get it. It's like, come on. I can put on my like old school hat here for a second and be like, come on, go see the patient. Don't you know what that means? Well, maybe not, right? Like there's been a whole lot of, I think historically there was a lot of urban lore, legend that was passed down from student to student about, oh, this is what this is how Dr. Stevens like things. Oh, this is when you work with Dr. Moore, like this is, and I think some of that gets lost when there's not as much interpersonal interaction amongst learners.
I have a question.
Yeah, please.
So in this scenario, right, and M4 is probably a Gen Zer.
Mhm.
How do you reconcile this like need for specific instruction, need to have like expectations with, I'm just gonna look up a YouTube video if you can't teach me?
Yeah.
Like, how do you reconcile those two?
Yeah, because they're seemingly opposite, right? That's a great question, Ross. So I think here's how I try to think about it. When it comes to content, they are listening to others tell them what they need to know, often on Reddit or that, right? So content, they want to experience content at their own pace in the way they learn best. When it comes to performance, right? When it comes to performing, that when you're in the clinical setting where it's like, okay, I'm doing something now, not learning, I'm doing something. I think that's where they're wanting that very clear expectation setting. Does that maybe make sense? So like learning, I want to do it on my own. Doing, I want someone telling me exactly, showing me the path, telling me exactly what to do. And why? I think it's about this stress performance curve. Like this is nothing new. This impacts all of us, right? That there's probably like this medium stress level where our performance is at its peak, it's optimal. I think what some psychologists believe is with this kind of tendency to be on the anxious end of the spectrum, that many folks, that younger learners are like, they're living here, where their performance might be like on the other end of the curve. So what we need to do is just, how can we make this less anxiety provoking? One of those is expectation setting. How can we make it less anxiety provoking? Giving balanced feedback, reinforcing feedback. And this is kind of about that brave and safe space thing, right? We all know that like to grow, you got to get out of your comfort zone. I got to push you like, oomph, right? We don't want you here in the stress zone. So I think our challenge when you're supervising students, when you're working with residents, is to just like try to own this and name it and say like, wow, like yes, we don't want you to be here. If you're here, you got to raise your hand and say, hey, I need help. I'm panicked. I'm stressed. I'm not sure what's going on here. I need more direction. And also us as educators say, you can't stay here all the time. Can't stay there in the green bubble. All right. So this scenario does not apply to any of the residents in this room or any of the residents in my program. Let me just call that out. So, an imaginary PGY2 is on a blank rotation, but it's a busy one. but it's one that let's say it's CCU. CA3, something that my residents don't love, right? Okay. It's just not perceived to be as relevant to this individual on their chosen career path. So they've submitted 3 absence requests for the month. They want to go to their college roommate's wedding. They're not in the wedding. They just want to go. They have a family reunion and they want to take a day off to take their dog to the vet. And also the coordinator lets you know that they called in sick for a fatigue and headache. They didn't have a fever. They weren't nauseated or vomiting, just didn't really feel up to coming in today. All right. What are some of the tendencies maybe that might be underlying this behavior?
Lack of work experience with someone.
So maybe lack of work experience, right? Like they don't, like, oh, I can't, I've got days off, right? I get days off. I get sick days. I get vacation days. Why can't I just take them whenever I want? Yep.
Just used to running their own schedule, as you said, they're
Yeah.
working on their own.
When you've been used to self-paced, individualized work, this idea of learning, right? You spent 7 years learning. I just been learning, right? Going to class, taking tests. This idea of trying to balance that of I can do it on my own time with my clinical responsibilities. And even if you don't think this rotation is all that customized to your career path, I bet the physicians or the faculty, the attendings that you're working with probably think it's pretty important and probably need you there. Yeah. What else? So how do we adapt our educational programs to be able to respond? Now, let me also say that, yes, we want physicians and medical providers to be present in the lives of their families and do those things, we want you to be able to go to your family reunion. But I think there's also a recognition that you can't go to everything, right? You can't go to especially in med school and residency, everybody is getting married, right? There's 20 weddings a year. Maybe you have to be selective about which weddings you go to. And nor should anyone feel the need work when they are truly too ill to work. But yet there's also this rub sometimes of okay, I don't feel the best, but are the patients that I was going to see today better off if I take some Advil, have an extra cup of coffee, pull my boots on and head on in versus ask a partner to see him, get rescheduled, right? That's this delicate balancing act that we in the medical profession have to contend with.
I'm going to go back, Kristen.
Yeah, please.
I think I think one other item is that, especially John and I, and those of our generation, they're just you came in no matter if you were on death's door.
Yes.
We have to change the
We've got to change
mindset and embrace, wellness is such an overused term, but we have to realize that what we did was probably not appropriate. And to expect that of our learners is inappropriate.
Yes,
right? So I think just
absolutely.
accepting those differences, but also educating them about time management and that you're in a profession where taking a day off is not like taking a day off from the bank. That our patients need us, and if we are absent, somebody else is having to take on that duty, and patients may suffer from that. So, like you said, making sure that the thinking process of why you're taking a day off is clear, and anticipating that, yes, my dog needs to go to the vet, but is there a day during the week where Conklin doesn't need me as much, and that might be the best day to schedule my vet appointment.
Or I need to find a vet that has Saturday morning hours.
Exactly. Or,
Right, that's part of it. And I think that's a brilliant call out. And I think that, what's really hard about residency in particular, guy, is that it's a dual role. You are both a learner and an employee, right? You play an important role in healthcare delivery and your absence makes a difference, right? And I think, how do we navigate that? Exactly as you said, like part of what people write a lot about professional identity formation, and it is not, and I want to call this out and say loud and clear, it is not making people do all the terrible things that we used to have to do, right? Like that's not what we should aspire to do. But somehow we have to socialize into the medical profession and negotiate some of those values and norms and change them and adapt them when we recognize like, hey, this way we used to do it where we like tried to kill people, that wasn't good. No, the power.
It's just gonna turn off if he doesn't do that.
Oh, okay, yeah, cancel. Yeah, okay,
And you're
and
fine.
we're almost done.
They're followed by me and I'm.
Yeah.
Oh, no rush.
So we've talked about this amazing cohort of humans that are in our midst, that are in this room and coming in the years to come. They are diverse, determined, entrepreneurial, want to make the world a better place. Like, wow. If we think about some of the challenges that may have come about through different parenting practices, the different generational differences, we can overcome those. We just have to do things differently. We have to adapt. We have to like maybe coach and teach a little bit more in the soft skills and interpersonal communication, social skills, help people learn differently. But like friends, I truly believe, and I'm not just blowing smoke because I'm outnumbered here. This is the group that is going to revolutionize medicine for both our patients and our profession. I think these qualities, right? This idea about making a difference, about leaving a mark, about equity, about work-life, we say work-life balance and it sounds bad, but about like physician well-being, about boundary setting, about innovation in how we deliver care, right? Like this is the group that's going to say like, hey, we don't need to do it this way anymore. Let's do it better. Now, who can we learn from? Old faculty, myself included, our medical schools, our residency programs, like this has been done before by Clint Eastwood. You're like, what? So Clint Eastwood, 1976, directed his first major motion picture film, Outlaw Josie Wales. It was a Western. 20 years later, still rolling, directs a love story, The Bridges of Madison County. 10 years later, the sports drama, $1 Million Baby. People win Oscars and stuff. 10 years later, he directs a musical, right? Like that is adaptation. If Clint Eastwood can do it, then I really think we can too. And here's what he says about his long and illustrious career. It's not about you. It's about them being the people that he's working with, the actors that he is directing. Things change. They always do. It's one of the things of nature. Most people are afraid of change, but if you look at it as something you can always count on, then it can be a comfort. And I think as we have seen, baby boomers to Gen X, to millennials, to Gen Z, like that change never stops. And our job is but to see that change as opportunity. And hopefully today you've gotten a sense of how we can embrace those opportunities and really enable this generation to achieve their potential and make medicine better for us all. So thank you very much. Any other questions? Closing thoughts, Dr.
Eastwood. Follow a quote
You may.
his movies, which I think is very pertinent to this. Johnny